Good morning, everybody. This is a rainy day here in Athens, which is very strange because usually we have sunshine. But what can we do? We have rain today. Zoe, good morning. It's a great pleasure to have you with us.
Good morning.
So, we're celebrating today the World Mental Health Day. And I would like to say right from the beginning that it is a day for which the WFMH, the World Federation for Mental Health, deserves great credit, because this is the organization that has initiated this with support from the WHO and the Carter Foundation. And each year, the WFMH creates a very good book concerning the talks that the contribution and the talks delivered during these sessions, which are worth reading. We have here Gabriel Yves-Bizarro, who is the Secretary General of the WFMH, who will talk later. I would now like to thank the Ministry of Health, and especially the Deputy Minister for Mental Health, Zoe Rapti, for the cooperation. I would also like to thank the organizers of the meeting, ERA Limited, Mrs. Tonis and Mrs. Marandu in particular, the volunteer support of Androniki Gadzelaki has been offered to us, and also my daughter Electa for the logo and the artistic work. And most of all, I would like to thank you, the speakers, for accepting to participate. And I'm very glad to say that everybody who has been invited has accepted to participate, which is very encouraging and touching. So I would like to ask the treasurer of the Society of Preventive Psychiatry, Mrs. Greta, to introduce the Deputy Minister, Mrs. Zoe Rapti. Eleni.
Good morning, ladies and gentlemen. Now, I would like to ask the Deputy of Minister of Mental Health of the Ministry of Health, Mrs. Zoe Rapti, to address the audience.
Your Excellencies, dear colleagues, professors, esteemed professors, ladies and gentlemen, I would like to welcome you all to today's event, Mental Health in an Unequal World, that is co-hosted by the Ministry of Health and the Society of Preventive Psychiatry. And thank you all for your participation in this meeting. It is a great honor to discuss with you the crucial matters of mental health, especially during these unprecedented times of the COVID-19 pandemic. This pandemic has brought significant effects on people's lives, especially shining on mental health. This year's theme for World Mental Health Day is mental health in an unequal world. Racial, ethnic, economic, and ideological discrimination has always been a burden to mental health and an obstacle to effective and wholesome provision of mental health services. The efforts for mental health policies is actually an effort to support human rights. COVID-19 had a significant impact on mental health systems, as we all know, and that is resulting in many people with mental health illnesses not receiving the proper treatment they deserve and continuing to experience stigma and discrimination. At the early stage of the pandemic, Prime Minister Kyriakos Mitsotakis foresaw the need to focus on improving the general population's resilience and created a special portfolio for mental health and addiction in Greece. This was being done for the first time. Since the beginning of the pandemic, the Ministry of Health, in alignment with WHO's principle, leave no one behind, has taken a series of steps to address the needs of the general population with a focus on the most vulnerable groups. Among others, we increased public funding for mental health by 62%, which is something which was important and needed in Greece. And for the first time, the funding of the social cooperatives for mental health was included in the regular budget of the Ministry of Health, ensuring the right of the mentally ill to reintegration in the society. We are providing also psychosocial support to adults, children, and adolescents across the country, including our isolated areas, mountainous areas, and the islands, through hotlines, through telepsychiatric services, and through digital tools. We're also developing mental health facilities in the community, such as residential families, facilities, nursing homes, mobile units, and day centers, for the psychosocial support of different target groups across the country, with a focus on children, adolescents, and the elderly, which were most affected of these categories by COVID-19. Early intervention services in psychosis were legislated for the first time in Greece last December and now are under development. We also operate addiction prevention centers throughout the country and a digital map so that the citizens can identify all the available mental health services they need near their community. We create also collaborations and synergies which are of vital importance to us with national and global actors and organizations such as WHO, Europe, UNICEF, and other ministries and local authorities. And that is why, in collaboration with WHO Europe, the Greek Ministry of Health recently conducted a joint review of the current state of the mental health services in Greece to improve our mental health system. This joint review led to the creation of a National Committee for Mental Health, which will work and draw the National Action Plan for Mental Health for the next decade. We will be focusing on protecting the rights of mentally ill patients. Also, in collaboration with WHO Europe, we convened in Athens after it was the first live Congress, the Athens Mental Health Summit, as we call it, in July, and the summit led to the Athens Mental Health Declaration, which is recognized as a stepping stone to the adoption of the European Framework of Action for Mental Health 2021-2025 of WHO and the launch of the Pan-European Mental Health Coalition. Last week in Brussels, I had the honor to actively participate at this launch of the Pan-European Mental Health Coalition by the WHO Regional Director, Dr. Kluge, independent of Her Majesty the Queen, Matilda of the Belgians, and the EU Commissioner for Health and Food Safety, Mrs. Kyriakides. National and international collaborations are the sure path for change and real progress in the provision of mental health services in our regions and the globe. Our vision is to shape our mental health network so everyone can achieve optimal health through equal access to people and community-centered quality services with zero tolerance to any exclusion. Thank you very much for the invitation and the joy to be addressing such an important audience.
Thank you very much, Mrs. Minister. And now I would like to ask the President of the Society of Preventive Psychiatry and past President of the World Federation for Mental Health, Professor George Christodoulou, to address the audience.
Thank you very much, Eleni. The topic of this year's World Mental Health Day is mental health in an unequal world. Dear friends, inequalities exist at various levels in nature: higher animals versus lower animals, animals versus plants, and so on and so forth. But if we concentrate on humans, we have inequalities between the rich and the poor, and the future perspectives of these inequalities are grave, because the rich become richer and the poor become poorer, especially in circumstances like the present circumstance with the coronavirus. And this has been exacerbated, as I said, during the coronavirus epoch. We have inequalities between men and women. We have inequalities due to race, gender, ethnicity, sexual orientation, gender, identity, human rights, stigma. All these parameters create inequalities. We have inequalities at global, regional, country, and individual levels. We have inequalities in health provision to people. We have huge treatment gaps anyway, which involve all social classes, but especially this refers to the poor. We have inequalities in provision of mental health services versus physical health services. And this is exemplified by the fact that only 2% of the total budget for health is provided to mental health, just 2% globally. And of course, access to mental health care in people with mental health problems is impossible for a proportion of 75 to 95% of the low to middle class population. Dear friends, the philosopher Aristotle, the philosopher, used to say that one of the greatest injustices is to treat unequals in an equal way. This dictum has two readings. One reading is that we should support the gifted in order to achieve, in order to make the world progress, and thus we're all going to benefit from these achievements. The other reading is that we should support the weak, the poor, the deprived, the underprivileged. We should encourage them, empower them, and advocate for them, so that no one should be left behind. A category that is constantly left behind is the category of people with mental illness. It is to these people that this year's Mental Health Day is dedicated. Thank you very much for your attention. And now we can proceed with the list of speakers. Professor Vasilis Bozikas has asked me to be the first speaker because he has other obligations. So I'm asking Vasilis Bozikas, who is the president of the Hellenic Psychiatric Association, to speak, and his theme will be promoting mental health in the coronavirus epoch and beyond.
Thank you very much. Thank you very much, Mr. Christodoulou, and I would like to thank you for your invitation. Deputy Minister of Health, Zoe Rapti, and dear colleagues, the theme of the World Mental Health Day is mental health in an equal world. It is obvious that this theme was chosen to highlight and then to implement certain policies to deal with factors that contribute globally and locally to financial and social inequalities that have a negative impact in mental health. Such factors are gender, race and ethnicity discrimination, poverty and unemployment, immigration, as well as discriminations caused by sexual orientation. The COVID-19 pandemic, together with the applied multi-level restrictive measures, has generated a unique combination of an unpredictable and stressful biomedical and socioeconomic environment. This environment has introduced a real-life threat, involuntary and drastic everyday lifestyle changes with uncertain financial prospects, alongside with minimized coping and stress management possibilities. The combination of so many different and vital stressors may lead to acute as well as long-term direct, indirect, and even transgenerational unfavorable effects on physical and mental health. However, not every individual will experience the same level of negative impact on health and well-being during the pandemic, as several additional national, socioeconomic, environmental, behavioral, emotional, and cognitive factors can moderate individual resilience and coping. In other words, the pandemic has had an impact on everyone, but some population groups could be at particular risk of poor health outcomes. Data from studies conducted during COVID-19 pandemic concluded that the most exposed groups for mental health problems were mostly the already well-known high-risk groups for mental disorders in general. It is important that these vulnerable groups are not only identified, but policy measures are put in place to reduce consequences of the COVID-19 pandemic and lessen the risk of developing mental health problems and prevent further widening of inequalities. I would like to stress that COVID-19 vaccination is the most effective primary preventive measure against the short and long-term consequences in mental health and well-being of the entire population caused by the pandemic. Unfortunately, not all countries have equal accessibility to vaccines. Low-income countries in South America, Asia, and especially in Africa are being left far behind in the race to vaccinate populations. About 46% of the world populations have received at least one dose of a COVID-19 vaccine, but only 2.3% of people in low-income countries have received at least one dose. During the pandemic, but especially in its aftermath, that with vaccination we hope to come soon, the question that rises emphatically is what modern mental health services are needed. In a recent meta-analysis published in Molecular Psychiatry by Solmi et al. That addressed epidemiological data reporting age at onset for any ICD or DSM mental disorders, the proportion of individuals with onset of any mental disorders before the age of 14 was 34.6%, before the age of 18 was 48.4%, and before the age of 25 was 62.5%. The peak age at onset of any mental health disorder was 14.5 years. Moreover, young people who are in early stages of mental illness typically present with fluid and undifferentiated symptoms that do not meet diagnostic or severity criteria for entry in adult services, where typically are referred patients with a restricted subset of large stage phenotypes or chronic mental disorders. Young people with emerging distress, social impairment, substance abuse, self-harm or suicidal behavior are unable to access early, efficient, and appropriate mental health care at time most needed. Consequently, youth-friendly stigma-free services targeting on full-blown disorders, but also in specific mental health problems in the most critical years of onset should be established. This will enable appropriate and effective interventions to be delivered in when the mental disorders emerge. These services can also be interwoven with community awareness campaigns, which have been proven to improve knowledge, reduce stigma, and decrease duration of untreated illness. Evidence for youth early intervention services has been compelling in demonstrating increased access and engagement, reduced rates of relapse and hospital admissions, but also their cost effectiveness. It is obvious and can easily be understood how important this evidence is from a health economics perspective in deciding where the investments for mental health should be directed. Moreover, for Greece, these services will lead, together with the necessary modernization of the involuntary admission legislation, to a solid and significant reduction of the involuntary admissions, which in our country remain higher than any other European country, and they have been estimated to be more than 50% of the total annual psychiatric admissions. Although epidemiological and research evidence clearly indicates the need for youth early intervention services, this should not preclude early intervention services for younger children and elderly, which are also necessary for prevention and ongoing management of several mental disorders. This includes for younger children disorders like attention deficit hyperactivity disorders, learning disorders, and anxiety disorders, and for older adults, preclinical detection, and early stages management of Alzheimer's disease. In addition to target peak onset period for mental disorders, prevention-based program aiming at earlier developmental periods and key risk factors are required to prevent the emergence or alter the trajectory of mental illness. Regarding the former, there are encouraging findings to suggest that the transition to first episode psychosis can be prevented or delayed following early intervention program for psychosis risk syndrome. Targeting modifiable risk factors that may have cumulative effect is also critical for the prevention of mental disorders. Risk factors contribute to the development of multiple mental disorders, increase their severity, but also serve as common negative outcome factors. For example, maladaptive family functioning, including parental mental illness, substance abuse, and delinquent behavior, domestic violence, physical and sexual abuse and neglect, was the stronger predictor of several chronic and severe mental disorders. Prevention and alleviation of childhood trauma may further prevent the onset of, or lessen the severity of several mental disorders. Total removal of childhood adversities has estimated to lead to 30% reduction of lifetime prevalence of mental disorders and about 20% decrease of disability and 17.5% decrease of days out of role caused by these mental disorders. As the theme of the World Mental Health Day is mental health in an unequal world, it should be highlighted that the stigma and discrimination experienced by patients with mental disorders affect their physical and mental health, educational status, and income, but also affects their loved ones. People with mental disorder, mental health problems have the right to equal opportunities and perspective that permit them to fully participate in all aspects of life. Thank you very much.
Thank you, Professor Boudikas, for this interesting presentation. I would like to stress the fact that you have underlined yourself that in places like Africa, in continents like Africa, the availability of the vaccine for coronavirus is minimal. And this is certainly a sign of great inequality. Another point I would like to stress is the fact that with reference to the presentation of Zoe Rapti, the Deputy Minister of Health, that it's the first time in Greece that we have a special sub-ministry for mental health. And this I consider as a great progress with reference to the understanding that mental health is very important today and in the future. We shall now proceed with the talk of Professor Peter Falkai, who is the president of the European Psychiatric Association. And the topic of your presentation, Peter, is guideline-informed care to ensure high quality. Professor Falkai.
Dear George, dear Mrs. Deputy Ministry, and dear colleagues, it's a pleasure to be invited. I'd just like to share my slides very quickly with you. I hope you can see them. So the point I want to make quite shortly, we have about 25% of people diagnosed with a psychiatric. About 10% are acutely ill and need and seek treatment. If we look at, let's say, the core of the severe illnesses, schizophrenia, bipolar disorder, and unipolar depression, they cost, for instance, for Europe, and if you can think about worldwide, of more than 200 billion euros per year. It is interesting to note that these costs are comparable to cardiovascular diseases, but 6 out of 10 psychiatric disorders are among the top human diseases causing lifelong disability. So indeed, obviously, we are cheap in respect looking what actually disability these illnesses are connected with. Why is this the fact? Why is mental illness special, and why does it need special attention in an uneven world? Well, only 50% of patients with severe mental illness actually show recovery. And we have sort of low recovery rates, and additional, we have increased mortality by 10 years. Non-recovery is correlated with residual symptoms, which are only curable with optimal treatment from early intervention, as was mentioned before, to multi-episode illness. So what is needed in an unequal world? Well, secure structures to diagnose and treat mental illness adequately. And this is by no means sure around the world. And secondly, ensure quality informed care. Is that possible? And the point I want to make is that we are not only asking for support, but we know what we're doing. So if you actually look at the range of guidelines we have between Europe, US, and South Africa, we have in almost every region of the world guideline give us advice how to treat psychiatric illnesses correctly. But we know exactly what we need the support for. So just my message is mental illness is frequent and disabling. In an unequal world, mental disorders do not receive the same attention as, for instance, oncological or cardiovascular diseases. On the other hand, psychiatry knows, for instance, based on guidelines, what is needed to guarantee qualitatively acceptable clinical care. Thank you very much for your attention.
Thank you very much, Peter, for this short but very comprehensive talk. Now we shall continue with the next speaker, who is Professor Gabriel Yves-Bizarro, who is the Secretary General of the World Federation for Mental Health. And the talk of Gabriel has the title, Digital Transformation, Leaving No One Behind. Gabriel.
Yeah, George, thank you very much for this invitation. And I want to thank the ministry for supporting it and all the colleagues who are present today. I want to start with a message from the UN Secretary General that we got yesterday about World Mental Health Day, where he says that the world is in a difficult situation. He knows that COVID-19 has caused a terrible toll on all our population. And he gave a single straight message that it was time for all of us to come together to commit ourselves to make the world a better place. And I said, we've just published it on our website. I also want to seize the opportunity to thank all the contributors to this year's World Mental Health materials, George and everybody who have done so much for it. Before now, I used to think that, that in developed world that we are doing very well, and that the others are suffering. But actually, what has shown to us is that no, that's not true. That each and every society is suffering, and there are inequalities between societies and between countries and co. And according to a former president of France, President Hollande, he says that the world is facing new catastrophe, similar to what we had in 1948, and we have to find new ways of thinking about it. And one of the solutions we have been thinking about is the role of technology. And so when you look at COVID-19, hospitals had to be shut down, people had to do many things from home. But it was unfortunate that people with mental illness were one of the people, again, who were disadvantaged. More than 75% of people with mental illness have little or no access to proper technology. And some of them have no access to even computers. And if we are to use guidelines to treat people and you want to use online treatment and algorithm, again, it means that this population will be further disadvantaged. So the WFMA did some work with the University of Bradford to look at this, so we published something in this year's issue. And the very key things coming up is that societies, we have to work together again in a collaborative way to ensure that we develop pathways that will include, the people who have and people who don't have. So if we are to tackle this inequality, and that social the social disadvantages continue to be there. So if, for example, you want to think about children, see one of the publications from UNICEF was that even for children, that the poor families have no access to good IT. And then the contribution from Red Cross that in crisis, again, we need IT to support people. So at all levels, so really, so we need to think about how do we integrate IT into our protocols and processes. So in 2023 will be the 75th anniversary of the formation of the WFMH. So we want to bring together again a new collaboration that will look at how, for the next 75 years, what we intend to do. How do we ensure that the guidelines are available in an easy way for all the populations of the world? How do we ensure that algorithms that are written actually are truly effective? How will we ensure that government can support the poor people and people who don't have to the IT they need? If you think about an older person, many older people struggle with IT. So if they're going to be part of this future, what is necessary for us to support them? So in a nutshell, so we have new materials in this year's World WFMH material, but we cannot do it alone. So I'm to say thank you to George. I know George will be one of the people who will help us to move this forward. We're looking forward to a new collaboration that will actually allow us to be able to think about the IT that will support mental health, support primary care, support psychiatry, support social care, so that we can truly tackle this inequality that happens all over the world. Once more, thank you for listening to me, and I'm here to listen and learn from each and every one of you. Thank you, George.
Thank you, Gabriel. Thank you for being so comprehensive and also brief. But I'm sure we'll have the opportunity to make further discussions on the interesting topic that you have tackled on. And now we proceed with the talk of Professor Roy Abraham Kalivajalil from India, who is the immediate past president of the WASP, the World Association of Social Psychiatry, and he is also the past Secretary General of the WPA, the World Psychiatric Association. And Roy will talk on the role of social determinants of mental health, with a focus on India, on the situation in India, if I'm not mistaken, Roy. Okay.
Roy, you are muted.
We can't hear you.
George,
Start from the beginning.
George, thank you for this warm invitation, and it's a great pleasure to be in this distinguished group. And we are very happy about this WHO theme, mental health in a vast, World Federation theme of mental health in an unequal world. I also see that the WHO is also promoting mental health care for all. Let's make it a reality. So I think that's a slogan coined by WHO. When in this part of the world, in the eastern part of the world, India had a very tough time, reaching 400,000 cases in a single day of COVID-19 cases. Now we have made a big turnaround, and the number of cases in India has come down to less than 5% of the peak level. It's about 20,000 to 30,000 per day. And also that the state from which I come, Kerala, we are very proud that we have a highest vaccination in the country, with more than 90% of the people vaccinated. But again, we see the rich-poor divide in a huge country like India. India has one of the largest number of billionaires and one of the largest number of middle class, 20% of middle class, and also we have poor people. So there is a huge inequity and a mental health gap. Of course, we know that the mental health gap in low and middle income countries is as high as 80 to 90%. And India has, unfortunately, mental health has not been a priority. We have been working on this for a number of years. There has been one remarkable turnaround. There's a number of people interested in psychiatry, medical doctors, taking up the specialty of psychiatry. has enormously increased. When I became a psychiatrist, we had less than 1,000 psychiatrists in India. Now we have more than 6,000. Now medical students are finding it more psychiatry finding it more interesting. And some of the challenges, for example, in the eastern part of the world, 4 groups have been disproportionately impacted by the COVID-19. One was the frontline health workers, which are doctors, the nurses, and also the para health professionals. Unfortunately, in India, 1,500 doctors had sacrificed their lives so far. That's a statistics from the Indian Medical Association. It's a huge number, and this is an equal number of other health professionals have also been lost their lives in the call of duty. Another group of people who have been affected severely are the students, because the schools and colleges are remain closed. It's now reopening, and we hope things will now improve. Then people who live alone, and they have remained very frustrated because COVID has kept them indoors and they have been a difficult problem. And then, of course, people with pre-existing mental health disorders. These are the people who have been maximally affected. We look forward to working together, and of course, we are all working for the Alma-Ata Declaration of Health for All by 2000, which of course remained a dream. I'm sure we will now go for the 2018 Astana Declaration of Universal Health Coverage. I'm sure all our energy should be focused on that, so that the inequities in the world will be addressed. Thank you very much.
Thank you, Roy. Thank you, Roy, for this very interesting talk. May I ask you a question? I think one of the most prominent inequalities in the world is the brain drain issue, which is very clear in countries with low income. Would you like to pass a comment on this issue? Does it refer to India? I think it does, but are there any solutions concerning this problem?
I think there has been a slight change in the perspective. About 2 decades back, brain drain was a serious problem. Now we call this brain circulation, because India has now many large-scale corporate hospitals, and hospitals which are right on the next only to the main major hospitals in the Western countries. We have people from all over the world coming to India for what you call medical tourism. Some of these doctors who are trained in the West are now coming back to India, and I think we are finding a solution for that. Thank you.
Well, this is a very appropriate term, very brain circulation instead of brain drain. Congratulations.
Yeah, I have coined that term
for this novelty. Okay, perhaps we'll have time to share this discussion with the others later on. But I would like now to ask Professor Danuta Wasserman, who is the world expert in suicide, who is the president-elect of the World Psychiatric Association, and has been the president of the European Psychiatric Association as well, many offices, Danuta, to speak about suicidal behaviors and prevention in the world during the COVID-19 pandemic. Danuta?
Thank you very much. Thank you very much for this kind invitation, Professor Christodoulou. And I would like to greet your Deputy Minister for Mental Health and congratulate to this post, because it is very unique in the world. I and dear colleagues and friends, in Stockholm it is shining weather today. And it is probably due to those climate changes we have in the world, an unequal world from many, many points of view. I will speak today about the suicidal behaviors during the COVID-19 pandemic in the world and some predictions for the future. As you can see on this slide in the upper corner, I would like to promote also the WPA World Congress of Psychiatry starting very soon on the 18th of October. So please spread this message among your colleagues because we need participants and they will be very interesting presentation. Next slide, please. Current global situation just a week ago shows that there are 234 million confirmed cases of COVID in the world. It is from the WHO statistics. And there are around 4,800,000 deaths due to COVID. Just from the December 2019, when the first case was reported in Wuhan, China. And then you know how quick development was all over the world. From the moment when in March 2020, WHO declares the COVID-19 as a pandemic. Next slide, please. This has, of course, very many different implications. Socioeconomic implications on health, on disrupted routines, economic difficulties, and as you mentioned before in your talks, increased inequalities. Also burden on family and relationship problems and uncertain future for maybe from the economic point of view in spite of many supportive actions of different all governments around the world. Next slide, please. The vulnerable groups, they are not only mentally ill patients, but also COVID-19 patients and their relatives, elderly, health workers, particularly nurses, females, and adolescents. I look from the population perspective, that in those populations, there are many articles showing increased anxiety, stress, sleep disturbances, helplessness, depressions, PTSD symptoms, suicidal ideation, and even suicide. Next PowerPoint, please. I did a systematic literature search, and the results will be presented for you for the 6th region of the World Health Organization. The results will show suicide rates during pandemic, in different periods of pandemic, in comparison with the years before, as well emergency department visits during the pandemic, and self-reported suicidal ideation. Next slide, please. There are 3 international studies with systematic reviews and meta-analysis. The first one, published from 21 high and upper middle income countries, shows that suicide numbers up to now remained largely unchanged or declined in some populations. As you can see, there are high and upper middle income countries included in those overview. Studies showing, including other countries, more maybe unequal from the socio-economical perspective. They show that suicide ideation and suicide attempt increase during the pandemic. Then we have some studies again from mixed populations which show that there is a fall in hospital presentations for suicidal behavior. If we go to the next slide, you can see that in the regions of Americas, there are articles published from United States and Peru. And United States, when decline in suicide rates was reported or unchanged numbers. So the decline was mostly observed among white residents, while at the same moment there was increased suicide rates reported for non-white residents and among Black people. So it is an obvious inequality showing in those data. From Peru, there was also reported overall decline in suicide rates, but among men, after an initial decline, suicide rates increased during the course of the pandemic, which means that from the completed suicide point of view, men were unequally highly represented. Next slide, please. In Australia, there were no differences in monthly rates. In South Korea, it's the same pattern, the decrease in the number of suicides during first months of the pandemic. In China, the decrease in suicide mortality during the first period was also seen. However, there was 139% increase in suicide rates in the 10 to 14 years age group. So young people were hit more by the pandemic concerning completed suicide rates. Next slide, please. In Japan was very interesting development. First a decrease in suicide for all groups, but afterwards an increase, and especially among females and adolescents. And interestingly, the increase in suicide rates for adolescents was not in the period of school closure, but it was during the period when the school closure ended. Next slide, please. England and Germany, as we have seen from the first overview from Europe, they were unchanged, mostly unchanged, completed suicide rates. Next slide, please. In India, there was reported reduction in the number of deaths due to suicide registered in autopsies, but we know that not all people have autopsy after suicide during the lockdown period. But after that period, a significant increase was seen. There are no studies from African regions and not from Eastern Mediterranean region concerning completed suicide. If we go to the next slide, please. We can see that during the first period, it was significant reduction in the number of suicide-related visits to emergency departments, and we can see it also for all psychiatric patients. But in the post-lockdown period, there was increased suicide-related visits in Birmingham, also in Italy, and in California, in the United States, in relation to the general psychiatric visits to emergency department. On the next slide, you can see data about suicidal ideation. And suicidal ideation is very closely associated to depression. And we know that depression is very closely associated to suicide, completed suicide. So it is probably some prediction from those data what we can expect in the future. So rates of suicidal ideation were significantly higher during pandemic than before, and also for suicide attempts from the studies in Texas, United States. Also from Czech Republic, we can see data that suicidal thoughts and other behaviors like attempted suicide, increased significantly, as well as in United Kingdom. No significant differences in Norway. Maybe materials were too small, or maybe the social network and economical networks by the government are very strong in Norway, as they are also in other Nordic countries. Next slide, please. So, summary of the findings. Unfortunately, there is the inequality that we lack data from South America, African, and East Mediterranean region. We have data from high and middle income countries. And the pattern we see in Japan with decrease of suicide, completed suicide rates in the first phase, followed by a statistically significant increase, probably will be observed in the other parts of the world as well. We can also see decline in the number of visits initially, but then a rise of suicide-related visits in the proportion to overall psychiatric visits. Next slide, please. So what were the protective and risk factors for suicidal behaviors? Living in high infected areas is a risk factor. Being infected or having experienced quarantine is a risk factor. Having relatives, having higher psychological stress, increased alcohol consumption, difficulties in accessing or understanding information concerning mental health intervention, and health and economic concerns is a risk factor for suicide. Of course, psychiatric diagnoses are the high risk factor also, but they are not yet studies showing suicidality in different psychiatric diagnoses. Protective actions or protective factors were better knowledge and better social network. Next slide, please. So, of course, what we need to do, I published with my colleagues recently how we need to adapt evidence suicide preventive strategies during and after the COVID-19 pandemic in World Psychiatry. Quite comprehensive article, so here is only a short summary. What we need to fight for is to have a better access to healthcare and treatment. So we need to use more telemedicine and digital services, to empower helplines, to give our patients and the public, which has mental health problems. As Peter Falkai showed, 25% of the world population have some kind of mental health problems, to give them better tools for self-care online, provide mental health support to frontline and healthcare workers. Continuous chain of care is extremely important, and we as psychiatrists, but also other doctors, need to have very good chain of care by telephone contacts, online services, and other means when the person-to-person visits are not possible. We need to give also mental health support to survivors of COVID-19, both patients and their families. We need to utilize all evidence-based treatments for mental disorders, which were also very beautifully shown by Peter. But we need to develop guidelines for remote assessment and treatment. And we need to develop guidelines for mental health support in workplaces, because we have many people in working places who have depression, anxiety, and stress, and we need to develop referral system. And after we have seen that the people are not feeling well in the working places. Next slide, please. From the public health care perspective, we need to fight to prevent suicidal behaviors, to restrict sales of lethal means of suicide. We have very good evidence published by the WHO that the restriction of the access to lethal means helps impulsive, desperate people to have another thought. It gives also a possibility for family, friends, and other sources of help to give the help to the suicidal person. We need to have policies to reduce harmful use of alcohol, but also maybe to have more information how to promote safe drinking, because we cannot forbid to use alcohol, which is integrated part of many cultural part of many societies. But information about promoting safe drinking would be very important. And then we need to support different gatekeeper activities and use gatekeeper resource materials from World Health Organization, World Psychiatric Association, European Psychiatric Association, American Psychiatric Association, etc. Next slide, please, and it is almost my last slide, is that we also need to think about school-based interventions. You remember what I showed, that adolescents, after coming back to school after pandemic, we have suicidality, completed suicide in those groups. We have completed, performed attempted suicide in this group. And they are evidence programs which are available, like Use Aware of Mental Health, Science of Suicide, and Good Behavior Game. We need informed teachers and parents to discuss the virus, effects of the virus, feelings of children, to counteract depressive feelings, suicidal feelings, and these last acts which can be prevented. We also need to disseminate information about responsible media reporting, which can boost suicidal ideation and give better examples how to solve suicidal conflicts and despair. Thank you very much. I think I have one more slide with thank you. So next slide, please. Yes, I would like to make also a little bit promotion for my book republished in second edition in 2021 by Oxford University Press, that the content is very broad, from the religious, cultural perspectives on suicide, through the theories of suicidal behavior, through the different determinants of suicidal behavior, determinants which Roy spoke about, and to different psychiatric treatment and intervention methods from the public health approach and healthcare approach. So thank you very much for giving me the opportunity to share with you the state of the art in the field of suicide during the pandemic.
Thank you very much, Danuta. This has been an exceptional talk. Very interesting facts globally. I would like to note that there has been extensive research everywhere in the world on psychopathology and quality of life and the other effects of the coronavirus epoch and the restrictions associated with the pandemic, which have shown increased psychopathology, anxiety, depression, stress, obsessional compulsive behavior. We did some research in our group, the Society of Preventive Psychiatry, which has shown a great deterioration of quality of life, and also increase in depression, anxiety, and other psychopathology signs. In view of this, one would expect a greater rate of suicide worldwide, wouldn't one? But from the facts that you have presented, it doesn't seem to be like this. Do you have
Yes.
an explanation on this?
Yes, maybe, I don't know, they are speculation, but of course we know that the social cohesion is very important. So I think being at home during this pandemic with the family, close family, and most of the families are functioning, even if there are tensions, it is a preventive aspect of suicide. And probably we can see the suicide among probably lonely people or when we have violence in the families, because we know that the violence in the family, in some families, increased. So if we will have some in-depth study in the future to analyze those completed suicide, maybe we will understand better also the protective role of the family and friends and the very risk promoting role of being alone or living in dysfunctional and violent conditions.
Thank you, Danuta. And now from the future president of the WPA, we move on to the present president of the WPA, to Dr. Afzal Javed, who is going to speak on global mental health, a WPA perspective. Afzal, you're with us. I can see that.
Well, good morning and good afternoon. Thank you very much, Professor Christodoulou, for this invitation. I'm extremely sorry that I was a bit late in joining you, but let me congratulate you on this very, very important initiative. The Society of Preventive Psychiatry obviously gets the credit, but I think the way the Greek Ministry of Health has been involved, that is probably one of the best examples that how we can utilize the expertise and the services of the policymakers when we are talking about mental health in a global world. And I must say that the Greek Ministry of Health and the Greek government is very, very important. I recently heard that you are probably the first country that has launched and that has started a legislation on early intervention. So congratulations, and we hope that the whole world will follow some of the best traditions that are being practiced and prepared in terms of future health and the future planning. Regarding my very, very brief presentation, I will just summarize what is really the talk of the town in terms of the importance of mental health. I must congratulate World Federation for Mental Health for choosing this particular theme, mental health in an unequal world. I think this inequality is not only visible in mental health or general health, but probably we are seeing this inequality in so many areas. You think about poverty, you think about housing, you think about social care. There are so many areas where this inequality is really coming up and becoming a challenge for all of us. But when we come to the mental health, I'm sure that speakers have spoken about this, and there will be more talks about this, that let's concentrate on the burden of the disease. If we compare with other illnesses, we do not want to underestimate or undermine the burden of the diseases by many other non-psychiatric conditions. But now there is an evidence that 25 to 30% of population will have one or another type of mental health problem. Whether you call it 1 in 4, 1 in 3, or 1 in 5. This is a very important point that in this world, the most inequality in areas of health and social care comes for the mental health. Now, despite having this high percentage or proportion of people in the population, in the community, presenting with mental health difficulties, unfortunately, the ground reality is that majority of our patients do not have access to treatment. If they have got the access, unfortunately, under-treatment is a norm rather than an exception. And this is not only prevalent in low and middle income countries, it is highly prevalent in many countries where the situation is considered as having a better healthcare systems. The second inequality, which is very, very important in mental health, is about the distribution of resources. WHO, in one of its publications, very clearly said that looking at the extent of the disability, if you find what is the ratio of the budgets or the resources that mental health get, is much, much lower. Even if you consider the burden of the disease around 12 or 15%, the distribution of resources are usually around 1 to 2%, and even in many low-income countries, less than that. So this is another big example of inequality in mental health when it comes to the delivery of services. Then there is another area. Again, we don't want to undermine the importance of other medical conditions, and that is the treatment gap. The facts are that if you look at what is the treatment available comparing physical illnesses with mental illnesses, whether this is high-income country or it is a low-income country. There was a very important publication in British Journal of Psychiatry a few years ago that compared the treatment gap about the provision of treatment, comparing in low, middle, and high-income countries, specifically with some of the physical illnesses like diabetes, heart disease, or asthma. It was a significant difference, not only in high-income countries, but also in low-income countries. That the disability or the burden of disease may be comparable with some of the physical illnesses, but when it comes to the delivery of the service, that unfortunately is very, very disproportionate. The third area which I would just like to emphasize is the capacity building or the teaching or training. It is a pity that still in many countries in the world, there is less emphasis on the teaching and training of psychiatry or mental health in the undergraduate students or the undergraduate studies. We know that there is hardly a big proportion of medical students who would be attracted or who would come to psychiatry and become a psychiatrist. Even in high-income countries and developed countries, this ratio is less than 10%. So what happens if the remaining 90%, or in some countries even 95% of the medical students, if they are not exposed to the extent and the impact of mental illnesses, how would they be able to treat, manage, or diagnose these disorders in their different dimensions or specialities. So I think the need of the time is that while we are emphasizing about the inequalities in mental health care, we need to convince the policymakers that number one, we are struggling to have accessible, affordable, and acceptable mental health care services across the globe. The second one is that despite having evidence that there is 25 to 30% of people or patients will be having mental health difficulties, the range of the services is much, much less. The third thing, when it comes to the resource allocation, despite having a higher trend towards the burden of disease, we are not getting what we should get. And of course, when it comes to the capacity building, it is not only for psychiatrists alone, all mental health professionals, psychologists, social workers, nurses, and allied and para mental health professionals. So we hope that today's deliberations and this particular concept of mental health day will generate some more discussions and some more insight. And I just want to conclude my remarks by emphasizing that World Psychiatric Association is committed to raise the voice not only for psychiatrists, not only for mental health professionals, but also for our patients. There is a need that our patients, carers, and families are equally represented when it comes to the planning or the policy making. And we do hope that WPA, in collaboration with World Federation for Mental Health and all other organizations, will be able to keep this flagged, not only in a national agenda, but also in an international agenda. So thank you very much, Professor Christodoulou. I'm personally grateful to you for inviting and involving WPA, and more importantly, raising this awareness and combining the efforts of your government, the Ministry of Health, with the professionals' bodies. Thank you very much, sir.
Thank you very much, Professor Javed, for this talk, which underlines the determination of the WPA to work in collaboration with other organizations, more specifically with the WFMH, which is the initiator of the World Mental Health Day, in achieving greater circumstances for our patients and for the mental health professionals. We're grateful for your talk. And now I will ask the two discussants to discuss what they have heard. I don't know whether Mr. Panagiotis Tsinganos is with us, but I believe that Nikos Christodoulou is. So Nikos Christodoulou is an associate professor of psychiatry, working as director of the psychiatric clinic of the Medical School of the University of Thessaly. He's the Secretary General of the Society of Preventive Psychiatry, and he's also the President-elect of the Psychiatric Association for Eastern Europe and the Balkans. Nikos Christodoulou, please take the floor.
Hello, it's very nice to see so many familiar faces today, who I haven't seen for a while, since, well, before the pandemic, I suppose. That's what separated us largely. But starting with this discussion from all those excellent talks, there was an interesting common theme here, and I am going to paraphrase Professor Falkai in a couple of phrases that he mentioned to sum up what everyone has been mentioning in one way or another. Professor Falcai said that we know what we're doing and we are cheap at doing it. Those were two phrases that he mentioned during his talk, and I'm putting them together now. Starting my commentary from Professor Falcai then, I would say that not only do we know what we're doing, we are also dirt cheap. We're much cheaper than what would be obvious at this point in time. I'm drawing this conclusion from both the WHO's evidence from the disability predictions for 2030 and beyond, which, as you know, puts mental illness pretty much at the top, at least for high income and middle income countries. So we are looking ahead at a further increase of the need for mental health investment. And this is something that's evident. It's right in front of our eyes. So at the moment, we may be cheap, but in the coming years, we will be dirt cheap because we will be called to deal with an increasing number of problems with increasing consequences, having the same means to do so. The funding is disproportionate for this. This is something that has also been highlighted by the Center for Mental Health in England. What they said was that the direct cost, which is what we're seeing in terms of investment in mental health, only accounts for about 15% of the total cost of care as far as mental health is concerned. And we're talking about direct and indirect costs, including human costs, which are very difficult to calculate. In any case, that means that the 3 to 5% of GDP that is typically spent in European countries towards mental health is much less than what in reality one would need in order to deal with the real costs of mental health. And that is going to get even worse in the coming years. Hence, we are dirt cheap, not just cheap. Gabriel Ibijaro then mentioned inequality in access to certain things. He mentioned technology, IT, repeatedly, which is something that services should have by default because it speeds up so much the efficiency of services. It made me think that inequality to access, both to services as far as patients are concerned, and to facilitations such as IT from the point of view of the professionals, is a very important point to focus. Increasingly, though, in the future, what we're going to be faced with is inequality in access to time to do things, time to plan, time to recover from excessive work, time for patients to have with their doctor in order to have good quality therapeutic relationship and a good quality of care. So very soon, because we are not too many psychiatrists, because the needs are increasing, we're going to be problematic in time, in our access to time to deal with things. So beyond IT, beyond other means, beyond access to services for patients, we're going to be short in time. Roy mentioned something which correlates very well with what Afzal said later on, moving on to Roy's talk and a bit of Afzal's. Roy talked about the circulation of brains. I am in the privileged position of having circulated my brain back to Greece from the UK very, very recently. So I can see how this can work and how this can be a very positive thing. But I'm also hearing from Afzal when he's saying that that is not his experience when it comes to trainees coming out generally in terms of their will to go into psychiatry, and how this is globally a problem, the shortage of psychiatrists coming out of medical school being a problem. In any case, going back to Roy's point, what he was talking about is that there may be a shortage of psychiatrists, but then they circulate. Yes, that's good, but it's not good enough. I was in a meeting the other day, and the director of the hospital wanted me to develop a service for medically unexplained symptoms, for somatoform symptoms, for the myriads of patients that they have in other specialties, and they don't know what to do with these patients. And I was left with a feeling of helplessness, because I know that about 40 to 50% in some cases of all patients in primary care have medically unexplained symptoms. They have somatoform disorders. They have all sorts of somatization. And those patients, it's impossible, simply impossible to, excuse the phrase, mop them up in psychiatry. It's just impossible. So I can see how difficult that recruitment problem is. And that is another inequality that we have compared to other specialties, which is again related to low investment and the higher need in the depth of time. Moving on to Professor Wasserman's point, I was very interested to hear that presentation. It moved away from that common theme a little bit, but it highlighted a very interesting model, a model of preventive psychiatry in practice, which is very rare to see nowadays. In addition to the so-called Swedish model yielding some really positive results as far as the pandemic is concerned, COVID-19 is concerned, even though initially many governments scorched that policy, eventually turned out to be really good. It also came out really good as far as preventive psychiatry is concerned. It is clear that simple measures, we saw that in your slides, Professor Wasserman, having a positive feeling about the measures, having a better understanding of what's going on, information, access to information, and having a good social surrounding, friends and family supporting you, simple measures like this, meant lower suicides. That is preventive psychiatry at its best. Very to the point measures, very effective measures, very simple measures, yielding a very positive result. So that, I was impressed by that. And last but not least, I wanted to point out the other point that Afzal mentioned in his talk. He talked about the distribution of resources and how the unequal distribution yields different outcomes in mental health in different countries. There is evidence in the literature that this phenomenon also works within the countries, regardless of their GDP. So I think there was a study by Pickett back in the early 2010 or something like that in the British Journal of Psychiatry that correlated negative outcomes in mental health according to inequality within countries, regardless of their GDP. So you had relatively high-income countries like the UK and the US coming very high in terms of inequality because there was inequality in access and inequality between the high-income individuals and the low-income individuals within the country. So what I would stress there is that, yes, I agree with Afzal's point. Inequality leads to different and bad mental health outcomes for people who are at the lower end. But I think that this effect is not distributed across countries, but across individuals within countries. And I would like to end those comments by thanking you for the opportunity to make them.
Okay, thank you very much, Nikos, for these comments. And now we have some time, since Panagiotis Tsinganos, I think, has not appeared, to speak between us. I have a comment here by Professor Dimitris Ploubidis, who is the former president of the Hellenic Psychiatric Association, who has commented that the role of the Hellenic Psychiatric Association and the Society of Preventive Psychiatry should be increased in mental health strategies and in the request for greater funding by the Ministry of Health concerning mental health. And I'm prepared to back this request. I think it's very good to point out this need. Now we have a little bit of time for discussion between the various panelists. But there is another comment here, which I will read, by Olga Theorodikakou, on behalf of the Telepsychiatry Scientific Section of the Hellenic Psychiatric Association and the Greek Suicide Prevention Center. We would like to congratulate you on this fruitful discussion, and so on and so forth. Now, would someone like to pass a comment on the commentaries of the discussants? Professor Javed, would you like to pass a comment on this?
Well, thank you very much, Professor Christodoulou. I think just staying within the theme of this session's inequalities, I think we should also try to look at what are the positive things that we can do despite these inequalities. And I fully agree with that aspect of telepsychiatry or use of digitalization in healthcare. I think this is a tool that has really streamlined most of our activities, especially during this pandemic phase. And we know, if we just look at the usage of the IT, it is the highest in the youth as compared to the other populations. Now, they do not speak with each other, they talk to each other using these smartphones. So why can't we use some of these tools to improve and to overcome this inequality? Because when it comes to the use of IT or the technology, that is almost getting a shape in most of the even low resource countries. So I think this is one area that mental health professionals should concentrate, that how can we use these modern technologies, not only in helping those who suffer from these illnesses, but also more importantly in promotion and prevention. I just want to add that WPA is currently working on developing some apps for the use in the low and middle income countries to access and to reach and to know about some of the common mental health problems. And similarly, we are also trying to use IT in terms of preparing some educational modules on different aspects of mental health for our students. So I think while we are talking about resources, the distribution of resources, my comment here would be that IT and the digitalization is an important tool, and we should try to explore this at all national, local, regional, or international levels. Mm-hmm. Thank you very much, sir.
Thank you. Thank you. Professor Yves Bizarro, would you like to add something?
Yes,
or make a point?
Yeah. Thank you very much for the comment from Afsad. You're right about IT can be a solution, but there has been some things we need to think about. When you look at people with mental illness, especially SMI, majority of them have no access to the proper IT. And even though we say 70% of the population of the world have some form of access to telephone, but it's not the same as the digital technology we're thinking about for people with mental illness. When you think about COVID-19 and the misinformation that's happened through IT, you can see that, if we don't manage IT well, that's what will be the case. So there are ethical issues that we need to consider about use of IT. We want to promote IT, we want to use it because we can cover a larger population, but there are those ethical issues we need to think about, the safety of data that people are talking about, and more importantly, IT support and funding for poor people, for poor countries. So you talk about COVID-19 vaccination, 2 to 4% of people in Africa have access to it, even though we know it's there. So really, so let's capture this as a thing that we can work in a collaborative way, involve government, involve private sector to say, let's find an IT solution that we can use for SMI. I know in England they are doing that now, that individuals are donating computers even to schools. So they are donating, it's not the government funding it. So really, so even in England, there is shortage of IT support. So that's the kind of thing we need, the way I'm thinking we should think about it.
Thank you, Gabriel. Danuta, I have a question for you. Have you seen any cases of suicide by proxy, in view of the fact that all these difficulties associated with the COVID-19 have been exposed very much through the media, television, and so on?
Not during the pandemic. There are no data about it during pandemic.
Okay.
I take this opportunity because I would like to ask you, I know that your deputy minister has a lot to do, so she is not here, but maybe you could convey to her that you have a Greece commissioner in European Union on, I don't know if she is on mental health or not. I have seen her in another webinar just a few days ago. Because to involve European Union in the example from Greece, to have this special department of health within Ministry of Health is extremely important, because then we will have direct channels to one person, one minister. Now we have channels to so many people, and they are working with so many different disorders and diseases. So I think it would be a very important step forward to improve visibility for mental health problems, needs of the patients, needs of the families, and needs of prevention. So I think that your webinar was really excellent to visualize that you have this minister, and then link this minister to your another Greek commissioner in European Union to work on for the sake of improving mental health.
I agree with you, Danuta. I think this was a very important step forward. I agree fully. I fully agree with you. Any other comments from any of the participants, or perhaps from the audience? We have a little bit of time, 2 minutes, in fact. If you want to ask anything, or if you would like to contribute something to the discussion. If not, I will finish by saying this concerning the conclusions. The basic conclusion, I think, of this meeting, for which I'm very thankful to all participants, is that social inequalities are detrimental for mental health. This is quite obvious. Inequalities produce quite a lot of problems in mental health, and especially to people with vulnerabilities. The other conclusion would be that funding inequalities between somatic health and psychological health should be abolished. This derives from the wrong concept that mental illness and physical illness are different, and that mental patients should be kept, whilst physical patients must be treated. It is the same, the channels are the same, the pathology is the same, the channels through which the pathology appears are the same. There is no difference except clinical expression. This should be conveyed to the public in order to promote mental health in the direction of prevention. And the last thing I would like to say as a conclusion, which derives from other meetings and other evidence, is that for every dollar provided for treatment of common mental disorders, there is a return of $4 in improved health and productivity. This is a dramatic conclusion that should be conveyed to the governments, that you must invest in mental health because it makes sense, not on humanitarian grounds only, but also on economic grounds. And this is the language that governments understand. I'm grateful to you for your participation, and I would like to thank everybody who was involved in this, including our two technicians, Michalis Andreavis and Dimitris Kaloupis, who have helped us to realize this meeting. Thank you very, very much and have a nice day.